Good morning, everybody. I guess it's good morning for us here in US, but whatever time zones you are, welcome to our webinar on ophthalmic manifestations of neurofibromatosis. I am Aparna Ramasubramanian. We do not have any financial disclosures. The objectives of the webinar are to discuss the various ophthalmic manifestations of neurofibromatosis type 1, to discuss the ophthalmology screening strategies for NF1, to discuss the management of plexiform neurofibroma, and to give an overview of the management of the ophthalmic features of NF1, mainly concentrating on optic nerve glioma. I am a pediatric ophthalmologist and ocular oncologist, and I am here at Children's Wisconsin. I am very pleased to introduce my panelists, and this is part of our multidisciplinary team for NF1. Dr. Chisholm, do you want to introduce yourself, please?
Hi, I am Smithy Ann Chisholm. I also am one of the pediatric ophthalmologists here at Children's Wisconsin. In addition to pediatric ophthalmology training, I am an oculoplastic surgeon, so do a lot of the surgery on kids who have eyelid and orbital manifestations of NF1. I am excited to be here today to share some information with all of you.
And I want to introduce our next panelist, Dr. Sarah Rumler.
Sarah Rumler. I am a pediatric neuro-oncologist here at Children's. I'm the acting director of our neuro-oncology program. I'm also the associate program director of our pediatric hem-onc fellowship.
So again, this is our multidisciplinary team taking care of NF1 patients. So I'm going to get started with introducing some ophthalmic features of NF1, some screening strategies, and then our panelists would discuss the specifics of plexiform neurofibroma and optic nerve glioma. So NF1, it is the most common inherited disorder. It is estimated to occur in 1 in 2,600 to 1 in 3,000 people. The original diagnostic criteria, as we are all aware, you needed more of the following. You needed cafe au lait spots, 2 or more neurofibromas of any type, or 1 or more plexiform neurofibroma, freckling of the axilla or the groin, optic glioma, 2 or more lesion nodules, a distinctive bone lesion, and a first-degree relative with NF1. We're going to talk about some of these things, and then we'll come to the newer diagnostic criteria, which has now changed. But this was the original NF1 diagnostic criteria. And if you look at the diagnostic criteria, 4 of these criteria involve ophthalmic features. So hence, ophthalmology manifestations are very, very common in NF. They make an inherent part of the diagnostic criteria, and the ophthalmologist's role is very, very important in the management of NF1. So if you could enlist some of the features of NF1, the ocular features, they are subcutaneous or intraorbital neurofibroma, uveal melanocytic nevi, or commonly known as lesion nodules, retinal glial hamartomas, the choroidal changes, congenital glaucoma, optic nerve glioma, and pulsating exophthalmos, which occurs due to absence of the sphenoid wing. This is what a plexiform neurofibroma looks like. The upper lid is the most common. Like I said, Dr. Chisholm would discuss plexiform neurofibroma in more detail, but they are complex nerve sheath tumors that are usually diagnosed in early childhood. They can demonstrate a rapid growth during childhood and cause functional and neurological deficits. They are at risk for malignant transformation. The incidence is around 10%, and when you palpate these tumors, the characteristic feel is called the bag of worms. They can be varying degrees of the plexiform neurofibroma, from very mild, causing just mild ptosis, to more moderate to very severe, involving the whole face. On MRI, this is what a plexiform neurofibroma will look like. For pediatric patients, amblyopia is a major consideration. Because they develop in early childhood, they are very amblyogenic. Like I mentioned, the treatment would be discussed by Dr. Chisholm later. Lesion nodules, again, part of the diagnostic criteria. You need a slit lamp examination to find out those small lesion nodules. And if you look at all patients with neurofibromatosis, 63.2% will have lesion nodules. And if you look at post-pubertal patients, 92% of them will have lesion nodules. So Post-pubertal, if you don't see leash nodules, the likelihood that it's NF is actually pretty low. And in eyes with leash nodules, 80% of them will have an inferior distribution. So really pay attention to the bottom quadrant to look for the leash nodules. The next feature is congenital ectropia on UVA. It is a non-progressive anomaly, and it is basically that at the pupillary edge, the iris pigment epithelium is visible. It is related to severe glaucoma on the affected side. The side with the ectropion will have raised IOP. And it is thought to be likely related to overexpression of the RAS MAPK gene. The other feature that can sometimes be seen is iris mammillations. They are more often seen in patients with oculodermal melanocytosis or nevus of Ota, but they can sometimes be seen in NF1 patients also. It's not a diagnostic criteria. And like I said, it can be seen in other conditions like PPV type B, but you might see them, and you have to differentiate these mammillations from leash nodules. The next manifestation is glaucoma. It is estimated to occur in approximately half of the patients with NF1. It's ipsilateral to the side with the plexiform neurofibroma and also ipsilateral to the side with the ectropion UVA. The glaucoma is typically unilateral. It's diagnosed anywhere from birth to 3 years. You can try topical medications to control the glaucoma, but invariably these patients need surgical management for their glaucoma. The next is the sphenoid bone dysplasia. As you can see in this MRI, there is no sphenoid bone. So right behind the globe, you actually have the brain tissue. This is a patient of mine who actually presented with enophthalmus. And then when I did an ophthalmic ultrasound, I was like, what is this tissue right behind? It was actually the brain tissue, which we figured out only when the MRI was done because there was no sphenoid bone. This is the patient when I took him in for surgery. This is not pulsating exophthalmos. This is the opposite. It's pulsating enophthalmos, but you can see the pulsations which will coincide with the pumping of the heart. So similarly, when you have a pulsating exophthalmos, you really have to look for the pulsations which will coincide with your pulse. Sphenoid bone dysplasia, the surgical management is very complicated. The surgical goal is for dural closure and restoration of the orbital cavity. It can be done through an intracranial approach or a lateral orbital approach, and usually this is done in conjunction with a neurosurgery and oculoplastic surgeons. The orbital defect can be tackled with a split bone graft or a synthetic bone cement or a titanium mesh. Next, coming on to retinal hamartomas. The retinal hamartomas in NF can either be an astrocytic hamartoma, an angioma, a combined hamartoma, or a retinal glioneuronal hamartoma. It can be any of these hamartomas. And you almost have to look carefully for the hamartomas because they are often very subtle. Next, coming on to choroidal changes, these have come to more attention over the last several years. Here you can see a patient with just mild choroidal pigment alteration, which you might attribute to even normal pigmentary changes. They are actually ovoid bodies in the outer choroid. They are hamartomous lesions, so they're very similar to leash nodule. But if you look at the incidence, it's actually higher than even leash nodules. Close to 100% of patients with NF1 will actually demonstrate choroidal changes. So hence it's been incorporated in the revised guidelines, and we'll talk about the revised guidelines. Clinically, sometimes they can be hard to see, but they are very obviously seen on the near infrared reflectance. If you have access to an OCT, the OCT side image, we will actually see the choroidal changes in NF. So if you look at the modified diagnostic criteria, this is the 2021 update, where they have actually removed the genetic component with a first-degree relative, and they have included only the clinical diagnostic criteria, which include optic pathway glioma, 2 or more leash nodules, or choroidal changes. You need only one of them to be included in the diagnostic criteria. Axillary freckling, 6 or more cafe au lait spots, two or more neurofibromas, and a distinct osseous lesions, which could be sphenoid dysplasia or tibial dysplasia or pseudoarthrosis of the long bone. So please follow the 2021 update of the neurofibromatosis guideline from here on. Moving on to optic gliomas. The optic gliomas occur because there is an alteration in the mTOR and the MEC pathway. And this is how they present. Sometimes they'll present with mild proptosis. And this is a child that presented with very mild proptosis of the right eye, but on examination had optic disc edema, and the MRI has the characteristic features of a glioma. MRI is the gold standard for diagnosis. This is on T1 imaging, it will appear hypo to isodense, and on T2, it will appear hyperdense compared to surrounding structures. And this is a chiasmal glioma in a patient with NF1. Again, show it demonstrates this is what a chiasmal glioma looks like. So if you look at historical approach to asymptomatic screening MRIs, this is the timeline on how things have progressed for asymptomatic screening. In 1994, it was demonstrated that asymptomatic screening was not beneficial. In 1997, the NF1 task force again said, we do not recommend asymptomatic screening with MRI. And then things changed because the French task force actually recommended a screening MRI for all patients with NF1 less than 6 years of age, or for those older kids that had some cognitive impairment where you could not get a reliable visual acuity. The 2007 NF1 OPG task force from US again looked at all this data and said they did not find a benefit. And then in 2016, the French modified their update saying there was no clear benefit for a routine MRI. And they also demonstrated that early diagnosis and treatment do not improve the visual outcomes. The 2019 American Academy of Pediatrics, again, did not recommend any annual MRIs. I know in some centers, they're still following the routine MRIs. So I'm going to briefly discuss what are the pros and cons of screening MRI in NF1 patients. This is a paper from 2015 by Dr. Prada et al. And they did demonstrate that screening MRIs might be beneficial for NF1 patients. And they demonstrated that the 15-month was the time period where if you did a screening MRI around 15 months and you did not develop any, it did not show any optic glioma, then likely they will not develop symptomatic OPGs. So again, it rekindled this whole topic on whether screening MRIs should be done or it is not required. This is a patient that actually was one of my patients that was detected on a routine screening MRI, a 3-year-old family history of NF, and the routine screening MRI showed the glioma. The kid ended up having treatment and had good visual outcome. But if you think about it, had this patient come to the ophthalmologist first, we would have likely picked up that disparity in that vision and ordered an MRI, and that would have come to detection. So there are some patients that get detected on screening MRI, which with a careful ophthalmology examination would have been detected anyways. When you look at the optic nerve diameters, do talk to your radiology colleagues that it is hard to clearly measure, especially when you have a bilateral glioma. So you have to rely on normative data. And also there is a normal progression of increase of the optic nerve diameter in the first 6 years of life. So when you're doing sequential MRIs, we don't know if this is normal growth in the first 6 years of life, or is this a glioma developing? So really rely on the normative data when diagnosing gliomas. The other question that comes up very frequently is optic nerve tortuosity, where there's an abnormal curvature. The nerve is not thickened, but it just has contrast enhancement. So it does not meet the criteria for glioma, but what is its importance is not clearly known. But people believe that children with optic nerve tortuosity are at a slightly higher risk of developing optic nerve glioma. The incidence of optic nerve tortuosity in NF1 is around 1/3 of patients. And when you're looking at tortuosity, how do you know if it's tortuous? You mainly look at two criteria. You look for lack of congruity of the optic nerve in several coronal sections, as demonstrated in the left top figure. You see the cut section of the optic nerve, but they are incongruous in spite of being at the same level, indicating that might be there is some tortuosity. The other is looking for the dilation of the subarachnoid space surrounding the optic nerve. And these two distinct radiologic features would suggest that the optic nerve is actually tortuous. So what are the pros of screening MRI? Early detection, it does identify high-risk features, just like we just discussed the tortuosity. And sometimes in these young patients, the eye exams can be very challenging, especially considering that NF patients can have some neurocognitive deficits. The visual acuity examination can be tricky. And also there is that benefit of maybe doing a single negative MRI, because 75% of the gliomas occur before age 10. And the average age for diagnosis is around 4.5 years. But the cons are the risk of sedation. FDA has warned that general anesthetic and sedation drugs in young children and pregnant women, there is a safety communication. It applies for patients less than 3 years of age, anybody who has anesthesia for more than 3 hours. So that is not for a screening MRI, and multiple. Again, if you're doing a single screening MRI, it may not be. And also there is this big study, it's called the GAS study, that looked at neurodevelopmental outcome at 5 years. It was an international multi-centered randomized study, and they found that if the duration of anesthesia is less than 1 hour, then no effects were noted at year 5. The other large study was from the Society for Pediatric Sedation, where they looked at 50,000 sedation anesthesia events. They did not find any deaths, but they did find 2 cardiac arrests that fully recovered. And they found that 1 in 65 children did have some airway-related events. So it's not a small number. 1 in 65 for a routine MRI may be quite significant. The other disadvantage of doing screening MRIs is that you will find what is called as an unidentified bright objects. They can occur in the basal ganglia, brainstem, thalamus, and cerebellum. They usually appear in early childhood, progress and decrease in adolescence. It's related to increased fluid in myelin or glial proliferation, and it might be related to cognitive impairment in patients with NF1. But then if you do see a spot, do you then do repeat screening, or do you terminate at that point? I would love for Dr. Rumler to kind of comment on this, either during her talk or during the question and answer session. So treatment is required for gliomas only if the vision disturbances occur, and majority of gliomas do not require treatment. So in our center, we are moving towards not doing any more screening MRIs. So if you have a patient with NF1 with no OPG, then you recommend that you get ophthalmic screening every year until age 8 years, and every other year from 8 to 18 years. If a glioma has been diagnosed and confirmed by MRI, then ophthalmology screening is every 3 months for the first year, every 6 months for 2 to 8 years, and annually from 8 to 18 years. And for the neuroimaging of the OPG, it's every 3 months for the first year, every 6 months for 2 years, and annually from 3 to 5 years. Both the ophthalmic screening and the MRI screening is subject to what you are seeing, clinically what you see. This is just a guideline, but you might increase or decrease the screening frequency based on the clinical exam. When it comes to ophthalmic screening, as much as possible, we want to get an objective vision assessment. For kids less than 2 years, if available, we want to try to do teller acuity cards. For pre-literate kids, you can either use Leah figures or HOTV matching. And as and when possible, we would like to get Snellen visual acuity on these kids. Routine visual evoked potentials are not indicated for NF1 or for diagnosing glioma at this point. Formal visual testing, as we are all aware, taking care of kids, it's very, very challenging, especially in the NF population. So confrontational visual fields alone are sufficient. There are newer headset-based, VR headset-based visual field exams. Our group personally does not have any experience as yet, but we're in the process of getting a VR headset-based visual field exam. So hopefully we'll have more data on that as more and more centers use it. Coming on to a very hot topic is OCT. How useful is OCT to diagnose and to follow optic nerve gliomas? It's especially useful for patients where you are not able to do an acuity or a visual field screening. It just provides some additional analysis. I usually tell families that OCT is giving me some objective data and the vision is giving me some subjective data, and you kind of have to put both together. For cooperative patients, you can do an awake scan. For sedated patients, you have to resort to an handheld OCT. But the disadvantage of the handheld OCT is that then it does not have the normative data. You kind of have to do the RNFL analysis manually. That again, during subsequent OCTs, if you're getting a slightly different cut, you might get a different value. So you really have to consider that when you're analyzing OCT. I think OCT is most useful when there's a disparity between the two eyes. If it's an isolated unilateral glioma, then it is useful. As you can see in this patient, the left eye is normal with an RNFL of 109. The right eye is an RNFL of 51. But a lot of people who do not have access to an OCT would tell me, you can clearly see that the nerve is pallor. You actually don't need an OCT to tell you that the retinal nerve fiber layer is lost. But this is a subjective assessment, so it gives you a number. So if it helps in pushing for the treatment, we can definitely utilize the OCT. Again, the treatment of glioma would be discussed by Dr. Rumler. Moving on to MEK inhibitors, again, Dr. Rumler would discuss the MEK inhibitors in detail. But when it comes to ophthalmic management, we have to screen these patients for side effects from the MEK inhibitors. The most common ones are optic neuropathy, retinal vein occlusion, uveitis, neurosensory detachment, and the MEK inhibitor-associated retinopathy. In children, what you usually see is outer retinal layers are separated on the OCT. Fortunately, the toxicity is much less common in children with MEK inhibitors, and it is reversible. If you stop the drug, it usually will improve on its own with no long-term sequelae. So if you see these side effects, you can discuss with your neuro-oncology team about maybe holding the drug for some time. It is not a contraindication to try the MEK inhibitor again. You can restart the MEK inhibitor, and sometimes you will see the outer retinal layer separation again, sometimes you will not see it. And this is what it will look like on the OCT. Again, visual rehabilitation is very, very important in patients with glioma. You have to heavily rely on your low vision specialist to give all visual aids. We have a lot of newer electronic devices. This is a patient with optic nerve glioma that is unfortunately no light perception in both eyes, but he is doing extremely well in school. He is a high school student now. We fitted him with what's called as the Orcam My Eye 2 when he was in middle school, and he has just flourished using this device constantly. I'm going to demonstrate how it's reading to you. So again, the device does do some facial recognition, but also will read any text that's in front of you, be it a grocery list, be it, going to a restaurant, looking at menu, it'll read everything for you. So, in current day and age, we really have to use all resources to help these kids. So thank you very much. And I'm going to pull up my polling question. If you could please go ahead and answer the polling question. The actually correct answer is retinal changes. That's the most common side effect with MEK inhibitors. We move on to our next talk.
Hopefully I will be able to get through this. This is kind of a detailed topic, but trying to give just a general overview of the treatment of optic nerve gliomas associated with NF1. So just to briefly review the OPG pathophysiology. So this is seen in about 15 to 20% of patients with NF1. And it usually occurs before the age of 6 years, but not always. That's not a rule. Most NF1 associated OPGs are low-grade gliomas in pathology, and they have an indolent clinical course. So this is an important distinction between NF1 associated OPGs and sporadic OPGs because they behave differently. And they can spontaneously regress. So as Dr. Ramasubramanian said earlier, we don't necessarily need to treat all of these tumors just because they're there. So indications for therapy for these are, it's rarely actually very cut and dried. So the primary indication is vision change, and that's generally what we use as our rule. So we usually have to have vision change over a number of different evaluations. So it's usually not just one instance where you see maybe a decrease in visual acuity or visual field. You usually have to see kind of, either a progression or, continued visual change. Radiologic and then secondary indications could be radiologic progression of the tumor. This is important when considering the age and reliability of the ophthalmologic exam. So not all patients, especially young patients, can provide a really reliable subjective part of the exam. And so if you have a patient who has like a rapidly progressing radiologic change, this may be an indication for treatment for them. Severe pituitary dysfunction. So generally, if they have one hormone, deficiency, that's not necessarily an indication, but, as you can imagine, because of the location of these tumors, they can affect the pituitary if they get large. And so if you have severe pituitary dysfunction or something like growth delay or something like that, that could be an indication for treatment. It's not frequent, but it could be. Non-indications, so not reasons to start therapy, would be just the presence of the tumor. So like we said, the majority of these patients actually do not need treatment for their OPGs. And then if there's a personal or family history of NF1. So just because a patient has the tumor and has NF1, it doesn't mean that you need to treat it. There are some factors that we found that generally can increase the risk of clinical progression. So this is usually in female patients. It's usually in patients who are less than 2 or greater than 8. And then if the tumor location is post-chiasmatic, so in the post-chiasmatic optic pathway, those tumors are more likely to have progression and are more likely to need treatment. There are many different modalities to treat pediatric low-grade gliomas. I'll let Dr. Chisholm speak more to surgery about these tumors, but a lot of times we don't do surgery because, it can be very morbid and can, really decrease or destroy the vision. And we do have other treatment options. Radiation is a possibility. We generally, and I'll go into this a little more later, but we generally avoid radiation in patients with NF1. Chemotherapy is definitely an option, and then targeted therapies are options as well. So the general side effects of chemotherapy, everyone, they all kind of have different side effects, but generally you can see nausea and vomiting, you can see bone marrow suppression, so their counts are low, their counts can get quite low. And if their white cells are very low, this can obviously be an increased risk of severe infection. Fatigue, hair loss, hearing loss with some of the chemotherapies, peripheral neuropathy with some of the chemotherapies, and then importantly, again, for NF1, a risk of secondary malignancy with certain types of chemotherapies. So this table is wordy, but I think the things that I wanted to point out, so if you look at this table, you can see the majority of the chemotherapies that we recommend for these patients, if we do recommend chemotherapy, include something like a platinum. So carboplatin is the most common, cisplatin is also used, and a vinca alkaloid. So usually vincristine, but vinblastine is also an option too. The regimens for these vary, kind of here in the US and in Europe and other, locations. Things are just a little different, but they're fairly similar in the fact that most of the time these regimens have an induction where the patients come in weekly for like anywhere from 4 to 10 weeks. And then these are usually followed by cycles. Usually they're about 6 weeks long, or they're usually like 3 weeks getting chemo, 3 weeks off, or 4 weeks getting chemo, 2 weeks off. So they get a break between, but it is a lot of visits, and the majority of the time the patients are coming weekly. They also occasionally need to get labs checked and those types of things too. Almost all of these regimens are IV chemotherapy. There's the fourth line down, I think. You can see the TPCD. Those are oral medications, except the vincristine, but the rest of them are, and the temozolomide is can be oral or IV, but the majority of them are IV. And the survival outcomes. So interestingly, typically when we think about treating brain tumors, we think about survival outcomes. But for NF1 patients, we have to think also about visual outcomes. So because we're thinking that's the main indication for treatment, so that's a reason why we want to follow these, or why we want to treat them. And so survival outcomes, as you can see, they're generally very good, but you can see most patients, or not most, but a little under half of patients will have progression of their disease. So PFS is progression-free survival. So that's for example, 5-year PFS is the number of patients after 5 years who are alive and do not have progression of their disease. And then OS, which is overall survival, is at that time point, that's the number of patients, or the percentage of patients that are alive, period. So some of them have progression of disease and some of them don't. And so I think a theme to look here is that the progression-free survival it's not great. 46%, 39%. The vincristine, the Packer regimen had really good numbers, but for the most part, we think these patients will survive. They will survive. These tumors are generally do not have a high mortality, but they can have a very high morbidity, especially with where they're located. But again, I think the important thing, and the thing that we're more interested in now, is looking at visual outcomes. So there are a number of studies, but a lot of these studies are there's a lot of heterogeneity in the studies, and multiple multi-system or systematic reviews have been done, but because the studies are so heterogeneous and because they haven't all measured visual changes the same way, it can be hard to kind of consolidate those findings. But what we have found is generally, I think the most important theme is that the visual outcomes of patients that are treated with chemotherapy, the majority of them have either improved vision or stable vision. You can see, though, around 28 to 41% of patients can have worsening of their vision. And so for us, this is just very important when we set appropriate expectations for families. So chemotherapy is an option. It's definitely an option, and it's something we consider and something we do regularly. But we do need to go into it with all the information, knowing that even if we do this regimen, the child's vision could still continue to get worse. The other thing that we found that is really important is that multiple studies have showed poor correlation between imaging and visual field or visual acuity measurements. So we do follow the MRI because obviously that's important for us. But I always tell families, if you had to pick between the ophthalmologic exam and the MRI, pick the ophthalmologic exam, because that's the data we're most interested in. And that also can show, a change or progression in disease earlier than you would see on the MRI. They're the type of chemotherapy. It's not chemotherapy per se. It's a monoclonal antibody called bevacizumab. This is a VEGF inhibitor. It's given IV. The main side effects are proteinuria, hypertension, bleeding. And it's usually mild bleeding, so nosebleeds or gum oozing, delayed wound healing. There can be some other serious side effects, but generally bevacizumab is actually a very well-tolerated medication. The regimens vary, but it's usually given every 2 to 4 weeks. And the way it works, as you can see on the right there, it prevents the VEGF and VEGF receptors from interacting. And pediatric gliomas generally express a high level of VEGF. And so we generally, most of the time, the bevacizumab is active against these types of tumors. So we typically would consider bevacizumab when we have a patient that has a rapidly progressing vision loss. So most of the studies that you can see here, most of them show that the response was very fast and it was effective, meaning we can kind of halt the loss of that vision. So we use bevacizumab in a patient that, has got a pretty significant vision change over a short period of time, so over 3 to 6 weeks. We also use for patients where the tumor's growing kind of quickly, and we really need to kind of arrest the growth, again, to help with the vision loss. And you can see that we can actually get improvement in the vision with bevacizumab. So bevacizumab is one where you can see both halting of the vision loss and improvement of the lost vision. I think the important thing to remember about bevacizumab is that we use it frequently and it does work. However, these responses are not necessarily durable, meaning after we stop the bevacizumab, you can have a patient who then, can have the vision loss again. The other important thing about bevacizumab is that we can retreat with bevacizumab. So often you'll have a patient who's on bevacizumab, their vision is either better or stays the same. We stop it for a while because they may have proteinuria, hypertension. Generally, those side effects improve. We kind of give them some time off, and then we can re-challenge patients with bevacizumab. And the side effects are generally not cumulative, meaning once you kind of let them recover, you can retreat them and they will usually do okay. Targeted therapies, I want to talk about this. It's something where we are very lucky in the United States that we have access to these medications off study. And so we actually use them very frequently here. It is a different case around the world. So in many countries, I would say the majority of countries, these medications are not accessible except through clinical trial. So I think it's definitely something that we need to think about and look into, but with the knowledge that, there are a lot of patients who will not have access to these medications. So I wanted to focus on MEK and BRAF inhibitors because these are the most commonly used. But as we said earlier, there is also the mTOR pathway, which we can use mTOR inhibitors for, but we're not going to talk about those because of our limited time. So we know the MAP kinase pathway activation in NF1. We know that NF, so neurofibromin, inactivates RAS. So by dephosphorylation, it will inactivate RAS. So loss of this function leads to RAS hyperactivation, which then drives uncontrolled cell proliferation and tumor formation. So the blocking pathway, it's logical then that if we block, down this pathway in patients with NF1, this could kind of turn off the on switch. So I always tell families, neurofibromin is an off switch, and when the off switch is broken, things stay on. But what we want to do is put another off switch further down that we can turn things off. So common side effects of these commonly used medications, MEK inhibitors, are dermatologic. These are by far the most common: rash, eczema, paronychia, hair lightening, GI, some fatigue, peripheral edema, ophthalmologic toxicity, which is very important, and some cardiac toxicity. And then BRAF inhibitors similarly, but these patients can have really significant photosensitivity. They can have some malaise or flu-like symptoms, and then that word is spelled wrong, but also ophthalmologic manifestations. And then when we look at targeted therapies in NF1 OPGs, common themes, these patients generally do have a response. It's often stable, but again, that's a good thing. I always tell families stability is actually a response because we want to kind of stop things from, getting worse. Generally, I will set up the family to expect stability, and then if we have improvement, that's great. And the survival outcomes from a lot of these therapies, they're not really reported, partially because, the data we have is still fairly new, I would say within the last 10 to 15 years. And then, other things looking at, for example, a phase 1 trial, like long-term survival outcomes are generally not what you're studying when you're looking at those studies. But these medications are generally pretty well tolerated, and they're oral medications, which is nice when we compare them to IV chemotherapies. Just very briefly, a word on tovorafenib. So tovorafenib is a newer medication. It's a pan-RAF inhibitor, so it's been really nice for us to use with our patients without NF1. However, based on non-clinical data, so I think it's a big asterisk there is non-clinical data in NF1 models, tovorafenib promoted tumor growth. So by far, we're all kind of scared to use it in our NF1 patients, so we generally don't use it. So then just very briefly, I think consideration of therapy choices for patients with NF1, we generally avoid radiation if possible because of the risk of secondary malignancy is higher in NF1 patients. Surgery can have devastating visual consequences. Chemotherapy has its own issues. Alkylating agents, platinum agents, topoisomerase inhibitors all have a risk of secondary malignancy, which is higher in NF1 patients. Platinum-containing therapies can affect hearing, which is important in patients who already have reduced vision. But targeted therapies, the long-term side effects are unclear. We also have kind of a paucity of data for these particular indications with targeted therapies. There's also the availability of therapies. Most of the time in most countries, we're thinking about the chemotherapy as being our choice. The location of the patient, their ability to come monthly versus weekly, a port, they need an implanted port, that's an infection risk, and then the age of the patient. All of these things go into what we recommend for treatment. These are my references, and then here is the question. Yep, so you can see not an indication, and family history of NF1 is the biggest one. So a patient just having a family history of NF1 without other clinical changes is not an indication for treatment.
All right, so like I said at the beginning, I am Smith-Ann Chisholm, and I'm going to be speaking on the surgical management of NF1-related ophthalmic manifestations. I have no financial disclosures. Objectives of this talk is going to be to understand the ocular manifestations that may need surgical intervention in NF type 1, review indications for surgery, and discuss surgical approaches and outcomes. We will be specifically talking about sphenoid bone dysplasia, which requires a multidisciplinary approach, optic nerve gliomas, which rarely require surgical intervention, as Dr. Rumler alluded to, and then plexiform neurofibromas will be the main thing we focus on, and why you need to be careful when you are treating these. So starting with sphenoid wing dysplasia. Clinical features, it is the characteristic bony lesion of NF1, and it can also be associated with plexiform neurofibromas. As you saw in Dr. Ramasubramanian's video, it can present with kind of this pulsatile exophthalmos is usually what they say, but can also have that, can be enophthalmic because that bone is missing. Can have vertical dystopia of the eye, strabismus, ptosis, and then when you get a CT, you see this gaping defect in the lateral orbital wall. So you just basically see brain right next to the eye. You can have enlargement of the middle cranial fossa, as you can see on this image here, and then widening of the superior orbital fissure. Indications for surgery are progression of the pulsatile exophthalmos. That's the most common indication, and basically that's that eye protruding and pulsating due to the transmission of the CSF pressure, since sphenoid wing is missing. You can have it, if you have too much enlargement of the orbital fissure, that can lead to instability of the orbit. You would want to intervene, herniation of that temporal lobe into the orbit. You want to separate those two tissues, both to keep the brain protected, but also to keep the orbit and the eye protected. And then things more kind of local to the eye, if you have vision impairment or strabismus, caused by those structural shifts. And then finally, if there's a significant cosmetic deformity, there's a reconstructive benefit to surgery in these patients from a psychosocial side of things as well. Surgical considerations. This is something that usually is not considered until you notice that a patient is symptomatic, has one of those indications. So it's not something that you usually go to, right away in a baby. But you can intervene usually quite early in childhood or adolescence, or if there's just progression of the deformity. These are very complex surgeries. So you can see a scan here of a patient who had one of these reconstructions, but it oftentimes, requires a full craniotomy, and then you can utilize bone grafts or different like titanium meshes, different types of plates to reconstruct the sphenoid wing. It's basically always done in a combination with neurosurgery and craniofacial surgeons in addition to oculoplastic surgeons. And with this being such a big surgery and near the orbit, vision loss is always a possibility. Patients need to be made aware that some amount of continued asymmetry is pretty much guaranteed, and there can be recurrence of the protrusion after this surgery. Moving on to optic nerve gliomas. Like we've heard about from both of our other speakers, these are slow-growing, low-grade tumors with NF1 as the primary risk factor. Most are diagnosed in children before the age of 5, and they will have vision loss, proptosis, strabismus, and it can progress to blindness. Indications for surgery. This is very, very rarely are you going to treat surgically because there's almost a certain risk of visual compromise since the glioma is coming from the optic nerve tissue. So if you go to remove any of that tumor, you are basically guaranteeing vision loss. Because of that, we oftentimes will just monitor these patients with sequential MRI or OCT and eye exams, or as we just heard about, there are chemotherapy options to treat that are much better, and even if they are just stabilizing, they are not actively, causing the vision to become worse. However, there are some rare cases where you do need to remove these tumors, and this is one of those cases. So this was a 6-year-old girl who presented with rapidly progressive proptosis and light perception vision in her right eye. Imaging was done and showed this very large optic nerve glioma on the right side, as well as an optic nerve glioma on the left side. And the decision was made to take her for surgery based off that she could not close this eyelid at all. So the eye was basically just entirely exposed, and there was concern that there had been malignant transformation, possibly of this optic nerve glioma, due to the rapid progression of her symptoms. So these, you can see some more pictures from intraoperatively. So before surgery, you can see how the eye really did not close at all, was very proptotic. In the surgery, you could actually see the tumor there back behind the eye, and basically we isolated all of the muscles on the eye and kind of elevated the eye in order to get back to that tissue and debulked as much of that tissue as we could, with the goal of being able to have her close the eye at the end in order to keep the globe protected. We went into this surgery knowing that this was not a vision salvaging surgery, but an attempt to get pathology and to make the eye more comfortable and try to salvage the globe. Pathology did just end up showing a low-grade optic pathway glioma, so there was not malignant transformation of this. She is currently being treated with chemotherapy, given this tumor, but also the glioma that she had on the other side. And vision in the right side is questionably light perception. So parents really feel like she can perceive some very, very bright lights. But again, this was not, the goal was not to preserve sight. Moving on to plexiform neurofibromas. So clinical features, this is kind of in this picture is a very mild plexiform neurofibroma, but you can see that kind of S shape to the eyelid. Feels like a bag of worms when you palpate it, and they can definitely expand, especially in adolescence. They are very difficult to completely excise, especially if they extend back into the orbit. And these can also undergo malignant transformation. So they can become a neurofibrosarcoma, which is capable of widespread metastasis, and radiation therapy is a major risk factor for that. So going back to Dr. Rumler's talk about why we try to avoid radiation therapy in this group of patients. This is a condition that we do surgery on more frequently than we do for optic nerve gliomas, but we still want to be very careful going into surgery for these. So we usually do want to see that there's some level of visual impairment, which can happen from an optic neuropathy from pressure on the globe, amblyopia due to occlusion of the visual axis, or secondary glaucoma. Sometimes we are doing it for facial reconstruction, again, thinking about cosmesis and the psychosocial aspect of things. Despite these usually being associated with ptosis, the eyelid oftentimes does not close well, and they have lag ophthalmos as well. So bad exposure keratopathy can be an indication for surgery, globe displacement, and diplopia. When you are going in to do surgery, there are two kind of main things that I take into account. One is the lesion itself, so debulking the lesion, and then the other is making sure that you actually address the ptosis. So going in and just taking away the lesion, oftentimes you're still going to leave these kids with ptosis because they've had this lesion that's kind of stretched their eyelid. Oftentimes the levator muscle does not work well either, similar to like a case of simple congenital ptosis. So you need to kind of take both of those things into account. As far as the lesion goes, like I had mentioned, complete surgical resection in the orbit is usually not going to be possible because, as you can see, in this picture, there's tumor that extends back behind the globe. So to get that all out, you would be putting the patient at significant risk of vision loss, strabismus, other issues. And whenever you leave residual tumor behind, it will there's a high possibility that it's going to regrow. The aim of the surgery is to preserve vision and improve function, not to eliminate the tumor entirely. And you need to make sure that you set these reasonable expectations with the families. So, a lot of parents in particular will, want to go in with the expectation that this is going to be curative, that it's going to be one surgery and it's going to be done and everything is going to be taken care of. And so making sure that you set those expectations that, hey, we're trying to debulk the tumor, lift the lid as best we can to make sure we're developing good vision, but that we do not expect this to be a cure, that we may need to use other chemotherapeutic agents in the future or do additional surgery in the future. And then as far as ptosis goes, I really kind of treat this like I do my simple congenital ptosis. So I will try my best to get measurements looking at the patient's levator function in clinic. This can be difficult, especially if they have a big plexiform neurofibroma, because that can just cause such a mechanical force on the eyelid that you can't see those excursions well. But if you are able to see that they have good excursions of the eyelid, you can do a more straightforward ptosis repair with an external levator advancement or a CMMR. And then if you have that very poor function, which is what most of these kids end up having, you need to do something where you connect to the frontalis muscle. So either with a sling or a frontalis advancement flap. And then going on to just showing some of my patients who have been treated in various ways. So this is a patient who is being treated with a MEK inhibitor. Similar to what Dr. Rumler said, we're really looking for stability with this. But actually with this patient, he felt like things slightly improved. And I actually do think you can kind of, his MRD1 here is probably, 0.5, and here it's maybe 0.75. It raised him just a little bit, but certainly stopped a rapid progression that he was having. So there can be a role for medical treatment in these patients. But again, expectation setting for parents that we don't expect it to melt away the lesion, really to just stabilize things and maybe get a tiny bit of improvement. And then you can do surgery. So this is a case that was successful. So you can see this patient has some bulkiness of his lid here. He was one where the plexiform neurofibroma did not extend super far back into the orbit. So it was easier to debulk the majority of the mass. So you can see the mass that was debulked there. And then I put in a silicone sling, and you can see after surgery, he is still a little bit ptotic, still has a little bit of fullness in that upper eyelid, but he's engaging his brow much less than he had to before to clear his visual access, and this has maintained over several years too, where we've not had to do anything further. And then unfortunately, this next case is sort of what you can see oftentimes with these cases, and why you need to be really careful with surgery and try to defer surgery as long as you can. So this is a patient who had a bad plexiform neurofibroma that was both anterior but also spread back into her orbit, where we went in and tried to debulk as much of it as we safely could and put in a silicone sling. And then you can see postoperatively over the years, really, if anything, has gotten worse. So now has recurrence of this anterior portion of the lesion as well as recurrence into the orbit, and it's making it so she can't close the eye. This eye is also an eye that has has a complete cataract or a white cataract and a complete retinal detachment. So it's a sick, sad eye in general. But this unfortunately can be what you are battling with NF1 and with these plexiform neurofibromas, is that they can just keep coming back over time. I wanted to touch on some other things to consider when you're doing surgery in this population of patients. So one is amblyopia. So amblyopia is something that as pediatric ophthalmologists, we always want to have in our mind, and you need to be thinking about this whether you're monitoring a patient clinically, treating them with chemotherapy, going to surgery. Always need to be thinking about amblyopia, and do we need to be doing patching or atropine drops or something to treat that? And then I think from an education standpoint with the parents, the most important thing is making sure they know that they also might need to continue this treatment after surgery. So, surgery, again, we're trying to preserve vision, we're trying to enhance it as much as we can, but we still may need to do some of these like medical treatment things after surgery too. Glasses are another thing that are commonly needed in our kids with NF1. Ptosis, just in general, can induce astigmatism, and this astigmatism can be much more profound when the eyelid drooping is caused by a lesion like a plexiform neurofibroma. Even with just simple congenital ptosis, it's been shown that surgery does not reverse the astigmatism, and that's true with various lesions that are removed from the eyelids and from the surface of the eye as well. So making sure that you continue to follow these patients, continue to do annual refractions, and keep them in the appropriate refractive correction as needed. Strabismus is another thing that you can see in NF1 patients. Some of them have just regular run-of-the-mill strabismus, but you can also have sensory exotropias from secondary to vision loss from optic nerve gliomas or amblyopia. And then these patients can also present with various nerve palsies if they have a brainstem glioma. So always keeping strabismus in mind as well, and trying to balance treating that along with treating everything else that is going on. I kind of had mentioned before, oftentimes these kids will have exposure keratopathy. And this can be from proptosis if they have either an optic nerve glioma or a plexiform neurofibroma that's going back into the orbit. Can be from a seventh nerve palsy if they have a brainstem glioma, or they can just have poor orbicularis tone and kind of abnormal eyelid architecture with a plexiform neurofibroma. So need to be aware of this going into surgery, and actually it can be an indication for surgery if you have poor apposition of the lid against the eye, but need to be very careful when doing ptosis repair. So I never set these kids super high. Again, just trying to aim to basically clear the visual access because they are at kind of a setup for exposure keratopathy down the road. And then finally, need to think about the fact that a lot of these patients are on MEK inhibitors, and that MEK inhibitors have an impact on wound healing. So if you are doing surgery on a patient that is also being managed by oncology, you want to make sure that you stop the medication at least 3 days prior to surgery, and then you don't want to restart the medication until you ensure that the patient is healing well. So you want to wait until at least your 1 week post-op exam, make sure the wound is closed and everything is healing well, but sometimes we'll wait even longer. And then finally, I want to end on the note that you do want to always keep in mind the psychological impact that this condition can have on patients, both from a cosmesis standpoint, a vision loss standpoint. It can be a really hard condition for patients to deal with. In one study, over half the patients with NF1 were at increased risk for clinical depression. And then there have been other studies that have shown increased mental health disorders in patients just with eyelid ptosis from other causes that are more easily treated. So keeping this in mind and making sure you have resources available to help your patients with that side of things if needed. Thank you so much for your time and attention. And I also have a polling question here. All right, very good. And the answer was radiation treatment. So very nice. And thank you. Thank you, everyone.
Now open it up for questions. I'm going to look at the Q&As that were posted, and I would request our Dr. Rumler and Dr. Chisholm to help me out with these questions. The first question is the sphenoid absence and brain tissue presence cause any neurological deficit? Dr. Chisholm, can you answer that, please?
Excuse me, it can. So it can cause fluctuations also in CSF pressure. So some of these patients even need to get VP shunts. So it doesn't in everyone, but it can. And so that is one of the reasons that it will sometimes need to be addressed surgically.
The next question is, why does optic nerve tortuosity predispose to optic nerve gliomas? I'm going to take that question. It actually doesn't predispose. It's just a structural, it just represents a structural change. It's not a precursor lesion, but sometimes if there is fluid accumulation or the nerve sheath is growing, it gives that tortuous appearance. So it's not causative, but it's to do with the biology of how that optic nerve and its sheath is structured. Next question is concerning OCT role. Is progression in OCT alone with no functional deterioration an indication for treatment, or the structural damage could happen as default with time and functional deterioration is the key? So I think functional deterioration is the key. If I'm seeing changes on the OCT, myself and Dr. Rumler would discuss it and will say, oh, let us see this kid back. Instead of 3 months, let me do a vision check in 6 weeks to make sure that's not a functional deterioration. Just because there is an MRI progression or an OCT progression, we wouldn't jump to treatment. We would still rely on the vision, but it's sometimes a key. It gives us an idea saying, is vision going to follow? So we do keep it in consideration, but we won't jump to treatment just based on the OCT. Next question is, what's the significance of anesthesia in these surgeries? Dr. Chisholm, this was posted during your talk, so I'm assuming it's for the plexiform neurofibroma surgery.
Yeah, from what I know, there aren't any specific special like anesthesia precautions you need to take in NF1 kids in general. So, just something where I would work with my regular team of pediatric anesthesiologists. Like Dr. Ramasubramanian mentioned in her talk, there is mounting evidence that early exposure to anesthesias, especially multiple exposures, can have deleterious effects on neurodevelopment. So that is something that I keep in mind. And I do try to, in general, with just my simple congenital ptosis patients, defer surgery until they're a little bit later, and particularly with neurofibromatosis patients, if they are doing okay and they are developing good vision, I will try to defer surgery until they're older, both from a decreasing anesthesia risk standpoint, but also decreasing the risk of having the plexiform neurofibroma come back. The older you can kind of delay surgery to do your initial resection, the less likely you are to have that recurrence.
Next question is, based on which criteria can we choose between chemotherapy or targeted therapy? Dr. Rumler, do you want to answer that?
Definitely. Yeah. I would say there's not a set criteria. I think a lot of it is patient by patient. So obviously the availability of these medications. So like I said, in the US, we have availability for the targeted therapies off study. But in a lot of countries, it is only through a clinical trial. If there's a clinical trial available, I think it's definitely a very reasonable thing to consider. I think the other things to think about are the resources that your family has. So, if you are giving chemotherapy, the patient is going to need to have a port placed. Are they able to come and get labs checked frequently? Are they able to, if the child has a fever, are they able to get them evaluated promptly? Those types of things. Are they able to come every week, for, a year or a year and a half to get chemotherapy? So I think there are some it's not like we said, it's not cut and dried. I think the other thing to consider is the speed at which these medications work. So historically, or when I was trained, it was chemotherapy was the thing that we did because it worked faster. And it's, you can generally get chemotherapy started fairly quickly. The way I was trained was chemotherapy is faster. But we're starting to see now actually the time to response could actually be a little bit faster with some of these targeted therapies, but we just don't have the data to help us back that up yet. The other thing is bevacizumab is also something that you can consider, and bevacizumab is one where you can definitely get that started quickly. And we have done bevacizumab in combination with either chemotherapy or with targeted therapies too. the long and the short is there's not really a set defined criteria.
Next question is, how is the visual prognosis in these eyes as they grow up? Like Dr. Chisholm was stating, amblyopia is definitely a major contributor to long-term vision, be it plexiform neurofibroma or glioma. And again, with gliomas, as we have all been saying, we don't have a magic bullet. We are only trying to preserve vision at the best. We sometimes get a few line improvement, which we'll take if we get, but our expectation is to just stabilize the vision. Next question, Dr. Chisholm, is for you. Do you remove whole orbital part of the optic nerve in case of optic nerve glioma, or only tumor fragments?
Really, it kind of ends up being tumor fragments. So like in that case that I showed there, trying to get the entire nerve with kind of its location back behind the globe without taking the globe out was not possible, but so just tried to remove as much of the visual tumor as we could. And really, you're only going to go back for surgery in a case like that. So really anything more mild than that, you would be definitely starting with other chemotherapeutic medical options, not going to surgery.
And next question is also your way. Does it recur after surgery? If you could answer, I don't know what they meant by surgery, so if you could answer for both plexiform and glioma.
So for both, yes. And so that is why I would say pretty much all of my patients now that I'm taking to surgery, actually, if they are severe enough that I'm taking them to surgery, I'm working closely with oncology to have kind of a plan in place for medical treatment following surgery, because they almost always are going to need that to then try to keep things stable.
The next question was, what is the method of surgery? I think they're probably asking the orbital approach.
So the orbital approach is based with that tumor that you guys just saw there. I did kind of every orbital approach you could take. So I did a swinging eyelid, came from temporal. I did a transcaruncular, and I also went from a lid crease up to the brow. So I kind of approached it from all directions, again, to just try to debulk as much tumor as we could. The photo that I showed was showing it from kind of that swinging eyelid approach coming from below, but did end up kind of going at it from various approaches.
Next question is, a 30-year-old man's eye was born with a white pupil and no vision. Can it be corrected with surgery? So I think this depends on what the white pupil is from. If it's cataract alone, I don't think there is any harm in going and removing the cataract. They have shown that adult amblyopes can also improve. So if it's cataract alone, I think it's worthwhile to go and remove the cataract. But if it is cataract and a total retinal detachment in the back, then it's probably you're not going to get much outcome. So I would say in that scenario, a good ultrasound, and then go from there. The other thing, Dr. Chisholm, I would have you comment also, is looking for signs of nystagmus. If there are signs of nystagmus, then it's probably the vision, vision loss happened earlier in childhood and may not be recoverable. For a 30-year-old, we don't know when it happened. So if you don't see nystagmus, I would take that as a good sign. Any comments, Dr. Chisholm?
I would agree with that. Yeah, so I would look for nystagmus. I would look for strabismus as well. Not that would mean you couldn't do surgery or couldn't get visual functioning back, but if they have strabismus, making sure that they're aware of it so that if they do get vision back, if they end up having diplopia, again, since you don't know when they lost the vision, just you want to be kind of prepared for all things. But I think if it's just a cataract, worthwhile to try to take it out. Relatively, could have a high benefit from a relatively low risk surgery. But if there's nystagmus, if there's significant posterior pole pathology, I would not recommend doing anything.
Dr. Rumler, if you don't mind taking this next question, does NF1 related tumor growth become static in older age?
Yeah, I mean, we do think that the older the patient gets, the less likely it is that their tumor is going to progress. So typically, if I see a patient who, is 8, 9, 10 years old, I don't do as frequent MRIs, and I also don't necessarily think they're at that high of a risk for the tumor to progress or change. So the answer is yes. I think there's other things to think about. Patients with NF1 can also get other non-optic pathway CNS tumors, and those ones, depending on their pathology, can definitely grow during periods of growth. But the NF1 specific optic pathway tumors, they do tend to, I would say, get like senescence or static, the older the child gets.
Thank you. Next question is, what specific preventive measures can be implemented to reduce the risk of childhood eye cancers, particularly retinoblastoma? Additionally, are there any effective interventions that can be undertaken during the preconception and antenatal periods to help prevent the development of such conditions in children? Thank you, Joshua, for the question. Maybe Andy is able to send you the link for the retinoblastoma webinar that we did in Cyberside, I believe 6 months ago, and for more details. But in a short few sentences, there is no way to prevent it. There's only early diagnosis when it comes to retinoblastoma. If there is a family history of retinoblastoma, we can actually do prenatal screening, where we start doing ultrasounds at 30 weeks gestation, and if we see tumors intrauterine, we'll deliver the baby at 37 weeks. If there is availability, in that scenario, you can actually prevent retinoblastoma. You can do in vitro fertilization and choose the blastocyst that does not have the mutation. But again, I would redirect you to that retinoblastoma webinar where we kind of go over these details. Next question, Dr. Chisholm, is for you. What do you do for plexiform neurofibroma of the upper lid when there is no vision? The patient already has secondary glaucoma with ophthalmos. This is kind of like the patient you presented.
It's really hard. So those become very individualized conversations with the family as far as like what are our goals. So if the patient is having some psychosocial issues with it, it is reasonable to go and debulk and try to lift the lid to kind of reconstruct the face. If that's causing issues, you do have to be conservative with that to make sure you do not make any exposure type keratopathy worse. If there is kind of an exophytic portion to the mass, kind of like the one that I showed, where it's the mass itself is rubbing against the eye and causing discomfort, that would be another reason to go and debulk. But if it's not bothersome to the patient, and we really don't think there is any room for visual rehabilitation, it is also something where we will oftentimes just choose to monitor and not do any surgery. So it really becomes a very individualized discussion with each individual patient and their family.
Thank you. How can recurrence of excised neurofibroma be prevented? Can you take that, please?
So I think waiting until kids are a little bit older. So like Dr. Rumler was saying, we can see kind of less growth and less recurrence. So if you can wait until kids are older, I like to try to wait until kids are at least 8 or older, if I can. And then also having a plan in place to, get them started on some sort of chemotherapy. Usually it would be a MEK inhibitor, shortly after surgery, once they've kind of gotten through the healing portion of things, to see if we can then keep things stable and keep it from recurring.
If I may add, we also really try to avoid the radiation. Like Dr. Chisholm had mentioned, and the poll question is also that you really want to avoid radiation because that does increase the risk of malignant transformation. So are there any requirements for enucleation? Dr. Chisholm?
Yes. So if you end up having an eye that is very proptotic, with exposure keratopathy that is blind and painful, so it would really be getting to that, again, blind and painful point. So if it is a blind eye but there's no pain, usually we're gonna do things to try to spare the globe. But if it is a blind eye that is also causing pain, then there can definitely be a role for enucleation.
Dr. Rumler, if you don't mind taking the next question, it is, what is the frequency of recurrence of optic nerve glioma after chemotherapy?
Yeah, so most of the data we have is with the chemotherapy, and I would say the recurrence is fairly high. The progression-free survival, usually 2 to 5 years, is between 40 to 70%. So that means like 70 to 60% of these patients recur. So it is really common for us to have to treat these patients with multiple lines of therapy, unfortunately, even though they have done a course of chemo.
Next question is, can you give us some advice as an ophthalmologist? So again, NF is a tricky disease, and I think you need long-term follow-up. So all NF patients need an eye exam at least once a year till age 8, and after that, every 2 years. Closely monitor them for all the features that we have talked about. If you want to even enlist it in your chart and say, has glaucoma, does not have glaucoma, has plexiform, yes, no, has lesion nodules, yes, no. So really watch for all those features. And then we are not recommending routine MRI screening. If you see any change, look for the pupils really carefully. Look for, subtle optic nerve changes. And as much as possible, try to get as good a visual acuity test as possible. It's not easy. And I think consistency helps. Sometimes, even if you're not able to get a good vision, you see these same kids back frequently, you will know by their visual behavior if things have changed. You cannot get a visual field done, but on your confrontational testing, you will know if there has been a change. And I would say really listen to the parents. They know if the kid's vision has changed, they will know. So I would say good history and good physical exam on a routine follow-up is what would be useful. Dr. Chisholm, any other suggestions?
I mean, I think just kind of the things that you use in pediatric ophthalmology in general, where, hey, if you're not getting a good exam today, don't push it, bring them back again, in a few weeks. Like because you will have a kid who is just not having it, and then a couple weeks later they will want to participate and do all the things for you. So you don't necessarily have to go straight to an EUA on every single kid, or try to get everything in one exam. You can also prioritize certain parts of the exam on different visits. So kind of utilizing the same skills that you use in kids in general to make sure you're getting all of the information you need, and bringing these kids back more frequently if you need to make sure things are going well.
Next question, I'm not sure. Maybe Dr. Rumler, you would be able to help me decipher this. When was used TPCV? Is that one of your, yeah.
So I think this question is asking, when would you use TPCV? TPCV is, it's thioguanine, procarbazine, lomustine, vincristine. So that's a chemo regimen. We do use that for recurrent low-grade gliomas. If you look at the data, TPCV compared to vincristine carboplatin, that was kind of a seminal study that was done, and the outcomes are similar, but the patients who got TPCV had worse side effects. The other thing I think is really important for patients with NF1 is that procarbazine and lomustine are both alkylating agents, and alkylating agents put a patient at a higher risk just in general of secondary malignancy. And so again, patients with NF1 already have a tumor predisposition. So, you can put them at a risk of similar to radiation, although I would argue the risk for radiation is higher, but definitely put them at a higher risk of getting secondary malignancies in the future. So a lot of the studies actually, even if they randomize patients, to like Vinc Carbo versus TPCV, they actually would not randomize the NF1 patients. Those patients would just go to Vinc Carbo. So TPCV is something you can use. It does have more side effects, and I would say is generally less well tolerated than carbovincristine.
Next question is, does stem cell therapy play any role in the treatments you are suggesting? Not anything concretely so far. I know there's a lot of study being done on optic nerve and stem cells, but nothing that's even come close to a clinical trial at this point. Next question is, what is the relationship between precocious puberty and NF1? And is it associated more with central or peripheral precocious puberty? Dr. Rumler, are you?
Yeah. I think the main association we see is that patients who have especially like a hypothalamic tumor, that can obviously cause, a hypothalamic derangement. So I would say I don't know that NF1 specifically is associated with precocious puberty, but NF1, or an optic pathway / hypothalamic tumor in that area because of the mass effect or because of it infiltrating areas of the hypothalamus can definitely cause pituitary derangements. And that would make it more like a central precocious puberty.
What's the prognosis for this condition? Overall, for NF, I think it depends on what are the features that you see. It depends on whether you have a glioma, whether we have a plexiform neurofibroma. I think the central message from our webinar is that there is not a cure. There's only a control, be it for glioma or for plexiform neurofibroma. You have to be cautious when you jump into treatments. So choose your indications wisely, and you have to monitor these patients long term. Last question is, when patient starts selumetinib, how long do you usually plan to continue treatment? Is it indefinite? So
this again is another kind of gray area. So we typically, our general rule here is, the data and a lot of the studies the patients were on for between like 24 and 28 months. And so we typically kind of at that 2-year mark, we kind of look at things and evaluate. If a patient is doing very well, if they're tolerating the medication just fine, we might consider continuing them on the medication. But generally at that 2-year mark, if things are stable and if things have stayed stable for a long time, we typically talk about potentially stopping the medication. There are some groups that are starting now to wean these MEK inhibitors or other targeted therapies with the idea that it could prevent some rebound growth, which we can see as well after stopping the medication. But usually 2 years is our general time frame, but some patients need to be on them for a long time. And I think the other exciting / frustrating thing about these types of therapies is, the way we study drugs is we study maximum tolerated dose, but it's likely that these medications actually probably have a minimum effective dose. So we can potentially use that to try if a patient needs like more longer term medication. The other big thing about these medications is that, they've been around for a little bit, but we don't have those really, really mature data that we have with the other chemotherapies. So we really don't know the long-term side effects of these medications too. So that's something to consider as well.
The next question is how we can counsel the parents regarding the different treatment options, including enucleation. I think Dr. Chisholm really alluded to this, multiple factors and, psychosocial impact. Dr. Chisholm, do you want to just?
It's just really honestly taking the time and sitting down with these patients. So, it is, they can be very long appointments, especially leading up to making a surgical decision, but it's worth taking that time and making sure that everybody has the same expectations in mind. Because again, you don't want to go into a surgery with the parents expecting one thing and you expecting another, and you being pleased on the back end, and the parents being like, no, this isn't what we expected. And then that becomes really, even more of a thing when you start talking about enucleation. Even in a person who has a blind, painful eye, losing the eyeball itself has a major psychological impact on people. And so just, again, making sure you're taking the time and knowing that everybody is on the same page going into it. It's kind of, you have to just treat each individual case as its own thing and make sure everybody is on the same page going into treatment.
The next question is, what are the most effective current strategies for early detection of optic pathway gliomas in children with NF1? And how do you balance routine MRI screening versus clinical ophthalmological surveillance to preserve vision? At this time, based on all the evidence we are not recommending screening MRIs. I think a good ophthalmology examination is alone sufficient. If you feel that's a borderline, maybe a borderline APD, but you can't get a vision on this patient, then maybe get a screening MRI. But routine screening MRIs for NF patients is not recommended at this time. We are towards our last few minutes. We'll take as many questions as we can. What are the main challenges in implementing standardized screening protocols in developing countries? I agree, it can be very, very challenging. That's why we are not recommending routine MRI. No matter which country it is, routine MRIs are not required for NF. If possible, if you are able to diagnose NF based on clinical diagnostic criteria, if you can do once a year good ophthalmology examination till age 8, And then once every 2 years till they are 18, that would be ideal. Next question is, have you ever got a case where it showed up suddenly without any prior prognosis? And if you did, what were its diagnosis? I guess you're alluding to a glioma that showed up suddenly. And that's not unusual. You see a patient for the first time, and then you see a glioma, and then you diagnose the NF also. They would be treated pretty much like any of our patients that we have discussed so far. If you are suspecting glioma, then you get an MRI, consult your oncologist, and as Dr. Rumler had shown, choose your regimen based on the multiple factors of feasibility and logistics. How do you deal with structural functional dissociation in log when there's a radiological progression with stable visual function? Do you follow based on radiological progression? So I think they're asking, saying if the vision is stable and if there's radiological progression, what do you do? And I think this, myself and Dr. Rumler discuss this constantly, saying there is a patient that radiology has progressed, but ophthalmology is stable. And I would say majority of the time, we would still just watch them. We would probably watch them a little more closely. I say every 3 months when you have a glioma for ophthalmic screening, but I would probably see them every 6 weeks. But unless there is a mass effect where the glowing glioma is pressing on some other structure, unless there is vision change, we do not treat. Would you agree with that, Dr. Rumler?
Definitely, yeah. That's something I try to make sure my fellows know, is that just, radiologic progression without any visual change is not an indication generally, unless, like you said, there are some extenuating circumstances.
Are there ongoing clinical trials or upcoming therapies that could significantly change the prognosis of NF1 related visual complications? I think Dr. Rumler, you should answer this.
Yeah, so there definitely are. I would say the majority of them are focused kind of on those targeted therapies because they are, I think they're kind of changing the paradigm. Low-grade glioma is the most common type of tumor that I see, brain tumor that I see. And they are definitely, I think, changing the paradigm in how we treat them. And NF1 patients sort of have their own specific considerations, but they are a big part of that group. And I think we're going to start to see, potentially earlier or more frequent adoption of these targeted therapies, which potentially, if you are catching these gliomas earlier, or you're treating them earlier, or treating them in a different way, that definitely could impact the visual prognosis.
Thank you very much for posting all these questions. It was certainly a very, very interactive session. I would really like to thank Dr. Rumler and Dr. Chisholm, not just for this webinar, but for helping me out every day with all our patients.
Same.
Again, thank you so much to the CyberSci team, especially Andy and Lawrence, for putting this together. And have a lovely day or a lovely night or evening.
Thanks, everyone.
Bye, everybody. Thanks so much.